So now I'll speak about financial toxicity and time toxicity in patients with multiple myeloma. These terms are new. Financial toxicity is the idea of these out-of-pocket expenses that patients and their caregivers have to deal with, either directly from medication copays, gasoline costs to get to the hospital or clinic and so forth, but also lost productivity. Many patients, for example, after transplant, don't return to work again, and that's immediate financial toxicity right there. Time toxicity is even newer of a concept. The idea that for patients who have relapse disease, they are champions. They'll move heaven and earth to kind of continue and do whatever they need to do to get in remission. But for patients with myeloma in remission, is all the stuff we're doing actually high yield for them in terms of the clinic visits, the phone calls, et cetera? We don't know. And some of that interactions may be toxic. Previous studies have looked at healthcare interactions, like number of days in clinic, which I think is important, but it's also important to note that some of the time toxicities that patients report may be phone calls with their pharmacy, phone calls with the clinic to schedule appointments and so forth. We're not capturing that in our existing kind of claims-focused analyses of time toxicity, of healthcare interactions and how burdensome it is for patients. So we sought to ask patients. We interviewed over 250 patients who had undergone transplant at our center and asked them about financial toxicity using a validated questionnaire called the COST instrument, and time toxicity using a kind of novel instrument that we put together with the help of patients in the Seattle area with myeloma. They were very instrumental in this process. And so just to summarize the findings in a nutshell, for financial toxicity, we found that regardless of one's disease status, the rate of financial toxicity was roughly stable. I might have guessed that those on active therapy would have more financial toxicity than those who are on observation or maintenance lenalidomide. We did not find that to be the case, which suggests that honestly, from diagnosis onwards, the moment that someone's diagnosed with cancer, that risk of impairment of their financial well-being and their sense of financial security for their families kind of continues indefinitely. We need to work on that. Time toxicity, predictably, 80% of patients who are on active treatment reported what we would call time toxicity. Understandably, there I wouldn't even say it as toxic because you're actually using the people back in remission. However, for patients on oral lenalidomide maintenance, 38% of them reported time toxicity, which we defined as in-person interactions at least once per month for patients who live more than 4 hours away, or phone calls at least once per week related to their myeloma. And so, can we fix all of that tomorrow? We can't, but I think it's important to focus in on that maintenance population and say, look, some of the things we're doing in terms of the logistics of lenalidomide, how often we're getting blood work for these patients, how much they're being asked to come into clinic for evaluation, may be somewhat superfluous because the whole point of maintenance is to be able to rebuild one's life. And if you're dealing with your clinic for myeloma once per week, 40% of patients are doing that for the long haul for years, we can do better.